Awesome. Can you all see my screen okay? Awesome. Okay, great. So as always, if anyone's joining us who hasn't before, there's no pressure at all to speak. Feel free to keep your camera and your microphone off if you'd like. Feel free to jump in anything in the chat. But there is absolutely very much a safe space if you do want to share or speak out. We love it. Okay. Let's get started. I've tried to cover topics that weren't in the writtens, but towards the end or at any point, if there's anything that anyone specifically wants to chat about, then please feel free. If there's anything that you feel like wasn't covered in the writtens that might come up, even though the same subjects could come up. Okay, first case. You are presented with a 4-year-old male entire Labrador from a farm in Queensland with a 5-day history of acute onset vomiting, polydipsia, and lethargy. He is now depressed and anorexic. He is unvaccinated but up to date with endo and ectoparasite control. On physical exam, he is quiet. His heart rate is 144. Normal pulses, scums are pale pink, CRT of 2 seconds with tachy mucous membranes, and mild generalized abdominal pain. Rectal temperature 39.9. First question, outline a problem list for this patient and justify any initial diagnostic tests you wish to perform. Does anyone want to jump in? We'll try and time keep. So the examiners will give you about 20 minutes or so per case, but they'll keep you moving on. So I know it's really hard when you first see this question to know how much to say or speak for, but they will gently move you along if you're to keep you on track.
So the problem list for this patient would be acute onset of vomiting, depression, anorexia, lethargy. Would you query the polydipsia based on the exact quantity it's been drinking, or is that something that's already been questioned in the history?
I think you could say polydipsia on your problem list and
Yeah.
set for extra credit, say I would quantify that with the owner. I think that's a great thing to say. Yeah.
Yeah. Pale mucous membranes, tachy mucous membranes, mild generalized abdominal pain, and pyrexia. I think I got everything.
Great. Do you think anything about his heart rate?
Oh, yeah, tachycardic, sorry.
Spot on. Great. Perfect. And do you want to justify any initial diagnostic tests you wish to perform?
So minimum database, CBC biochemistry. So CBC to check for anemia, given his gums are pale pink, and to check for systemic infection, inflammation that may suggest non-gastrointestinal related disease, so tick-borne disease or something like that. Biochemistry to assess organ function, quantify kidney function, particularly given the history of the polydipsia. Also assess liver function and a urine analysis as well to confirm normal concentration, rule out, kidney involvement, and then start also with some abdominal imaging. So some abdominal x-rays and ultrasound to exclude things like an intestinal obstruction or pancreatitis.
Perfect. Yeah, I think that's a great answer. Everyone happy with that? You want to add anything? Beautiful.
Sorry, I'm late.
Hi, Anna. Good morning.
Sorry, I jumped in. I'm sure you did a preamble, but the weirdest thing about a medicine like oral exam is that they ask you these questions and then they. Did you hear how Helen kind of paused at the end of your answer? They just leave these awkward silences and then you just keep on talking and keep on filling it. And you, Georgina, you did really well to just like, I'm done.
Oh, yeah.
Yeah. It's really awkward and you're just like, am I finished? But they're not going to say anything and I need to get, I'm really bad at being like, yeah, they're just going to be like, and then move on. So yeah.
Yeah, okay, that's good to know. Thanks.
You are suspicious of canine leptospirosis. Outline which further diagnostic tests are most appropriate for this patient, specifically to confirm your suspicion of leptospirosis and why. For each diagnostic test, consider its indications for use and limitations.
Did you want to have a go at this one, Julian, or?
Not particularly, but I can. Um, so I would do PCR on urine and blood for lepto and then also lepto serology. But given this is an acute onset, I probably expect the serology that it could be negative. So more hanging my hat on the PCR results. What was actually the question? I'm just for this patient. Um, those are the diagnostics tests that I would use for lepto. Um, I wouldn't then yeah. I feel like that answers the
I
question.
think it depends on the timing. So if this patient's been unwell for 5 days only, I think the indication for blood PCR is more strongly indicated. So the first 7 to 10 days is where the blood PCR is more highly indicated. Following that period, after about approximately the 7 to 10 day mark, the urine PCR is more strongly indicated, past the initial bacteremia stage. And then you'd also add in the paired titers, so perhaps repeating the serology at 2 weeks to confirm or clarify the diagnosis.
Yeah, great. I think that's a really good answer. The only thing does anyone want to add anything else?
Like a urine culture, maybe? Just for like other infections rather than just lepto.
Yeah, perfect.
Is dark field examination feasible?
No, it's available in like research settings, but we don't really use it clinically.
Not sensitive enough.
Yeah.
Yeah.
So I think you really touched all points. The only thing that I had on my potential mark scheme, I don't know if Anna agrees, is just, I know this sounds really obvious, but I would actually state PCR is looking for the pathogen itself and serology is looking for antibodies. I can't remember if anyone mentioned that or not. And I know that sounds obvious, but I would just
No, that's a good point.
go back to basics and just make that really clear. Everything you said is perfect. So the limitations, and Julian, what you did is perfect, to go back and read the test when you listed the tests and then be like, oh, what was the actual question? Considering its indications and limitations. So the limitations of that serology being that delay as we start. You could also mention the fact that this patient is not vaccinated, so that's helpful because we're not going to get any like weak positive from a vaccination. But I think everything you said was great. And then the PCR, like you said, blood PCR is going to be most appropriate in the acute setting, and then urine once renal shedding has happened. This patient has not yet had antibiotics. You could also say that because that's really important, because once the patient's had antibiotics, our PCR sensitivity is going to go right down, and then we might have to rely on our serology. Another limitation that you could discuss is just to touch on the renal shedding. So some patients can have like a falsely negative urine PCR. If renal shedding can be intermittent, even if it's a bit later in the disease process. But I think you kind of touched on all of those points. That was good. Okay. Question 3, provide an assessment of the above results. So we've got a urinalysis, free catch, just for anyone that's just listening, USG 1010, glucose 1+, protein 1+. The rest of the dipstick exam is negative or normal. A sedentary exam, there are occasional casts. An in-house leptospirosis snap test was positive. Leptospirosis antibody for IgG was weakly positive, 1 in 200. Lepto urine PCR was negative and lepto blood PCR was positive.
So the urine analysis shows isocynuria, which is consistent with underlying kidney disease, along with the glucosuria and the proteinuria, which is consistent with the damage to the nephron, particularly at the proximal convoluted tubule, and along with the CAST2. So that's very consistent with leptospirosis, as is the positive in-house SNAP test and the blood PCR. As we sort of touched on earlier, the urine PCR being negative is to be expected given the fact that this is in the acute initial stage of the infection within that 7 to 10 days. So we wouldn't expect that to be positive until after this period. And as you also alluded to, it can be intermittently negative with chronic renal shedding, depending on the immune response at the time. And with the weak positive IgG serology testing, look, would you say that you'd repeat the titers with everything else? Like, I'm not sure that you would repeat titers because you've got the PCR positive, you've also got the SNAP test positive, and you've got a patient that hasn't been vaccinated. So I would commence treatment for the leptospirosis with the IV ampicillin for 2 to 3 days, and then start it on doxy following this. I'm not sure. Would you clarify anything? It seems pretty. Diagnosis seems pretty consistent.
I totally agree, and I'd start treatment for sure. What would be one advantage of repeating the serology that's bigger? I don't know how to ask this. That's bigger than just this patient. What do we get from serology that we haven't got yet?
I guess you're testing its like immune response.
Mm-hmm.
I guess they give you like specific serovars when they give you the serology. They say
Yes.
the caniculoli or the other, I've forgotten what they're called. Yeah, you get the specific serovar, which
Exactly.
would be helpful for like an outbreak point of view and for vaccination and
Exactly. Yeah. So I definitely would, not necessarily because it's going to change your treatment plan for this patient, but exactly like you said, from a population level, it's going to be really helpful if we can always track which serovars are indicated. And of course, you can get cross-reactivity. It's not perfect, but I think it's going to still be helpful for, like you said, vaccine guidelines and things. Yeah, great answer. So yes, I would include it in the exam for that reason.
Yeah, okay, cool.
I missed the early part. Is this a dog or a bitch?
It's a male dog, male Labrador.
Okay, the 1+ protein wouldn't be unusual necessarily for a male.
Yeah, that's a great point, Jeff. We could definitely say that in the assessment of that urine, for sure. It could be like normal or could be indicative, like you said, of kidney disease. For semantics with the USG, what you said was a really good assessment of that, but I probably would try to avoid saying kidney disease and just say it's isotonuric, so the kidney, indicative that the kidney has reduced ability to concentrate or alter its USG. So that could include primary renal disease, or could be another disease that's causing the kidneys to not be able to currently concentrate. Does that make sense?
Would you say in line with the concurrent azotemia that we identified on the bloods, it would be consistent with?
Yeah, you could say that in the context of that. Yeah. But yeah, you could still get diseases annoyingly, like Addison's or bad hypercalcemia that could cause both, but that's semantics. Your answer was great. Yeah. And really good that you didn't pay too much attention to the glucose being there, which can happen with, with the glomerular damage from the lepto. Yeah, perfect. Great. Anyone got any questions about this case or anything they want to add?
Helen, with the treatment plan, would you ramble on about like acute kidney injury management and then like the longer term management of this patient considering its potential?
Yes, I probably would. That's quite a vague question. And I probably would. I'd talk about, your antibiotics like you did. really focusing on that you still need the doxy for renal clearance. And you can talk about the hospital setting, so however you want to manage his AKI. When you feel in the exam, like Anna said, that you're just kind of rambling, they will move you on if you're taking too long. So if you feel like you want to go into a full thing, worried if it's relevant or not, they will just gently say, okay, we're just going to move on now. Even if you feel like you have really fun stuff still to say, don't worry, it's because they won't stop you if you're in the middle of getting points.
Right.
I would say as well, I would like outline a treatment plan. Treating the leptospirosis specifically, I would do this. The renal management is very dependent on the situation. Would you like me to expand on that? And then and they can say absolutely, please, or no, that's like not in the like kind of question. So they can sort of clarify that.
And is there a difference between when they say outline a treatment plan and outline a management plan? Or do we mean the same thing when they say that?
Same thing.
Cool.
Yeah.
And never ramble on. Always make it concise so it's easy for the examiner to read. Make it easy for your examiner, and don't frustrate him.
That's such
Or
a
her.
good point. That's such a good point. That's a skill, isn't it, Jeff? Doing under the moment. Okay, ready for case 2? We've got a 12-year-old Maldisex Shetland sheepdog presents for straining to urinate and hematuria. You perform an abdominal ultrasound, which reveals a urinary bladder mass at the trijome. How would you obtain a definitive diagnosis, and what are the limitations of the available diagnostic methods?
Can you guys hear me? Sorry.
Yeah, we can hear
Hey.
you. Hi.
So you could do a urinalysis, but sometimes they don't shed. Sometimes the cells don't shed. So if it's a transitional cell carcinoma, it may not shed in that particular urine sample. So you may need multiple. You could potentially, depending on where you are, try to do a FNA, but there is a risk of tracking that particular mass through the body. I think that's the main ones there, I think.
I would also like to add you could perform, depending on how far the clients are willing to go, a BRAF test as a non-invasive test. And also you could perform a scope and perform a direct biopsy of the mass, which would eradicate the risk of seeding. Attempting to perform a traumatic catheterization is unlikely to be of diagnostic use, given the fact that it's in the bladder and not the urethra.
Do you want to tell me any limitations of the Cadet BRAF test?
So it primarily detects types of carcinomas. So it doesn't necessarily detect 100% of cancers within the bladder. So you're looking at about like a 70%, I guess, diagnostic accuracy. So if it's negative, you would still need to perform a biopsy of the mass.
Perfect, great. I think we've covered everything. So we've got a few diagnostics, and remember with all of them to give a limitation. So with the question, it is asking you to listen, but to give a limitation as well. So perfect. So like, is it Ziggy?
Yeah.
Hi,
Sorry.
Ziggy.
I was trying to look
Like
up what the
Ziggy
RAF
said-
test is.
No, but we can talk about it. So like Ziggy said, urine cytology, potentially we could say a limitation of that and just list them and then give the limitation so that you don't forget. Urine cytology, like Ziggy said, could poorly exfoliate. Also, like we discussed about with pericardial effusion, inflamed transitional cells, there can be a bit of an overlap between them and neoplastic cells, so your pathologist might not want to make a call. Like Ziggy said, we can FNA the mass. There is a risk of seeding neoplastic cells through that FNA tract. But in reality, if you've got a patient with particularly metastatic disease, you might have an owner that's willing to take that risk if it's already through the abdominal cavity. The Cadet BRAF, does anyone want to explain for anyone in the group that isn't aware of it or hasn't used it? What it is?
It detects the makeup of the cells, doesn't it? I actually don't know if
Yeah,
the test works.
it's a free catch urine sample, so it's really nice because owners can collect it at home, nice and non-invasive. And it's detecting a cellular mutation that's present in about 85% of dogs with transitional cell carcinomas of the bladder. So it's highly, highly specific, but about 15% of dogs will be BRAF negative. So if it's positive and you've got a bladder mass, you can be really quite happy that you've got a neoplastic process. If it's negative, exactly like Georgina said, you still would need to follow up if you're really suspicious. So the limitations is it's not perfect. You're going to have 15% of dogs with a transitional cell carcinoma that are negative, but because it's non-invasive and you eliminate the risks of FNA and seeding cells and things like that, that would be a good option to discuss. Cystoscopic biopsy, like Georgina touched on, probably the biggest limitation would be the invasiveness of it, but great option for a definitive answer. And traumatic catheter, like you say, you could still attempt that. There's still the same theoretical risk of neoplastic cells seeding down the urethra as you come out of the bladder. So I think you gave a good limitation that that might not be what we do. But perfect, great. Everyone happy with those?
Yep.
Good answers, guys. The patient is confirmed to have a transitional cell carcinoma. Discuss your staging plan. And remember sorry to jump in, remember in the exam, you don't have to say if the owner has the funds, you can just say whatever you like. If you want to go bananas, go bananas.
Yeah, that's right. The examiners are wealthy.
Yeah.
Okay, great. Well, maybe most efficient way of staging this patient would be to stick it through a CT scanner rather than
Excellent.
performing thoracic chest X-rays and abdominal ultrasound, as it's more sensitive for detecting micrometastases. The other thing that you're looking for is invasion into the surrounding and local lymph nodes, which is typically the first area of metastasis, as well as the chest or the pulmonary parenchyma. You would also sample any lymph nodes that were enlarged to further stage the disease. And then based on that would determine, I guess, which management approach that you took moving forwards.
Yeah. Perfect answer. So you could definitely jump straight to CT. And it's not wrong if you say thoracic radiographs and abdominal ultrasound. Not wrong to say full body CT. Really liked that you gave the reason for that it's more sensitive for METs, particularly in the chest, and that's where TCCs like to spread. So you mentioned local lymph nodes and chest. Where else can TCCs metastasize?
The lumbar spine as well.
Yeah, amazing. So for a bonus
Just
point,
CT,
I think,
why CT
yeah,
is better. Yeah.
great advantage is they can METs to bone. So you've got that as well.
Mm-hmm.
Beautiful answer. And a rectal exam, the poor old rectal exam that always gets forgotten about. I chuck him in because even you'll probably, if you said CT, you can do a full body CT, but if you said abdominal ultrasound, a rectal just to check for urethral involvement would be a nice thing to add in as well. Yeah, great answer. Okay, outline the treatment options for canine TCC available to the client and provide an expected prognosis for each treatment option given. Examiners love a prognosis. You're going to get that in all your questions.
Do you want to go, Ziggy?
Sure, I'll see how I go.
Go.
So prognosis is poor in these particular diseases. You've got potential chemotherapy options. I think cyclophosphamide is one of the particular ones in this case, and that can be used as metronomic chemotherapy as well. You've also got non-steroidal anti-inflammatories, of which I think piroxicam is the main one that's had the study based on it. I think mean survival time is usually around 6 months with these with chemotherapy. Surgical intervention is poor because it's difficult to suture the bladder back intact. Um, and then they often get repeated. Sometimes they get repeated bacterial infections, so you may need repeat urinalysis and potential antimicrobial therapy.
I guess another option, not that it's usually taken up, but is radiation. But limitation of radiation is the cost and the requirement for general anesthetics that need to be repeated sometimes like 2 or 3 times a week. And chemotherapy options, is methotrexate another option for TCCs? Or am I getting my wires crossed?
So I think the answer you gave is correct, Ziggy, in that you definitely could use that as you could use cyclophosphamide for TCC specifically. That's more of a rescue drug. We typically would rotate through a protocol that's more doxo, mitoxantrone, vinblastine, carboplatin. You don't necessarily have to give the whole chemo protocol though, but there is a reason that we typically with TCC dogs start with an IV chemo rather than cyclophosphamide. Does anyone know why that might be?
The resistance issues?
Um,
Better penetration.
we're gonna get better with the multi-drug protocol, but why we reserve cyclophosphamide as not a first-line agent for this disease specifically?
Oh, because of the cystitis. Like because this
Yeah,
is already a disease where there's urothelial inflammation and then you're giving it something else that's going to cause more
absolutely.
inflammation. Yeah.
Absolutely. Yeah. So because of that risk, and once they get an episode of hemorrhagic cystitis, you can't use cyclophosphamide ever again in that patient. It's not recommended to just take a break. And it can be really severe. And so if you've got exactly like Georgina said, if anyone that's just listening, cyclophosphamide can have a side effect of a severe hemorrhagic cystitis. A metabolite that sits in the bladder is highly irritating. So if you've got a patient that's got active hematuria, that can be a side effect that we want to avoid. So we typically use that for like rescues for these guys and start with an IV protocol. If you want to list drugs in this answer, that's fine, but you can still give a good answer without like giving a really detailed chemo plan. Do you agree, Anna?
I would actually avoid giving a chemo plan. I would say I would base any chemotherapy treatment on review with an oncologist if I only want to go ahead with that.
Yeah.
And then if they want specific chemo information, they'll say run through the side effects of cyclophosphamide that might be pertinent to this case or something like that. So they'll ask you if they want specific drug information.
So we said, oh, go on, Jeff.
Yeah, I can't remember the name, but the drug that's used for recalcitrant mast cell tumors.
Palladia.
Yes, I used that on one in combination with something else, and I can't remember what the other drug was. Once on a dog in Newcastle, and I got 9 months out of it.
Wow.
It's probably a non-steroidal, Jeff.
Yeah, I think it might have been.
Yeah.
At the time, which is a good few years ago when I researched it, there wasn't an established protocol for it, but I can see now that there is.
Yeah, I think it's becoming more commonly used, Palladia, for carcinomas, from what I've read.
Yep.
Does anyone want to, I'm being a bit mean, with prognosis, put a time frame on any of these options?
So 4 months with like maybe 3 to 4 months with no treatment. Perhaps 6 to 9 months with chemotherapy, or radiation options, depending on the patient's response to the chemotherapy or radiation. I think it really depends on the location of the tumor as well, though, because the closer they are to the trigon and the urethra, the more of an obstruction they cause. And typically the shorter their prognosis or their life expectancy, as they will get an obstruction quicker. So I would say possibly even weeks to months if it's located further up the urethra, primarily due to the secondary obstructive issues that they cause. And the further down into the bladder, perhaps the longer the prognosis.
Yeah, that's a really good point to touch on. And the reason it's important to bring that up is, again, I think this would just be for bonus points, but there is, even if the TCC is at the trizone and is non-surgically resectable, like Ziggy mentioned, stenting is an option for the urethra. And even though that's going to do nothing for the prognosis of the patient in terms of managing the neoplasia, it will increase their life expectancy because they're not getting euthanized from life-threatening obstruction if their urethra is stented open. So you could discuss that in one of your treatment options as well. So yeah, we typically say, like Ziggy said, pretty poor, like just weeks. If we do nothing, they'll often obstruct. With non-steroidals alone, you might say 3 to 6 months-ish. With chemo, sort of 10 to 12 months. There are some studies of radiation that patients have lived 1 to 2 years with good control. So it's good that you touched on radiation as well, and potentially up to 2 years if they're also stented, so that they're not at risk of euthanasia from those life-threatening urinary obstructions. Yeah, great.
And just to recap, sorry, Helen. So I know we're not going too far into chemo, but the chemo primarily used would be the doxo and the methotrexate, or was it a different one starting with N?
I typically, again, like Anna said, I would use an oncologist protocol, but typically we would do, I love that line, it's going to be doxorubicin, mitoxantrone, vinblastine, carboplatin, and cycle through them.
There's like staged ones, right? But the one that we used to use all the time is mitoxantrone with a non-steroidal, and you just give the mitoxantrone every 3 weeks, basically. It's really easy to dose, very small volumes, and it's just like low complication rate and stuff. Whereas then when people want a more aggressive protocol, we do a mixed.
Okay, great. Thank you.
Awesome. Did you guys have any oncology in the written? You didn't know?
No.
No. Okay, cool.
Not that I remember.
No, there was that cat with GI lymphoma.
Oh yeah, I forgot about that.
Oh, GI.
Fun. Okay, cool.
Helen, Olivia sent me through like what they've had and what she thinks is left.
I know, you got it. I think.
Did you get it?
I tried to cover them.
Yeah, great. Well done.
Yeah. Urorenal, respiratory, and neuro, we thought you might want. I didn't do a respiratory case because, sorry guys. Okay, let's move on. Everyone happy with that last one?
Yeah.
Great. A 1-year-old female de-sexed Bernese Mountain Dog presents to you for a 5-day history of lethargy and crying out when lowering her head to her food bowl. She presented 3 days ago to the clinic, and a colleague found her to have spinal pain and a rectal temperature of 40.0 degrees Celsius and prescribed oral meloxicam. This has had minimal to no change to her clinical signs. She is now reluctant to walk. On exam, she has a short, stilted gait, repeatable neck pain, and her temperature remains 40.0 degrees Celsius. The remainder of her neurological and physical examination is unremarkable. Outline your initial differential diagnoses for this patient and state your leading differential diagnosis. Sorry for that typo. Anyone want to do it?
So initial differential diagnosis would include discospondylitis, given the age, the temperature, and the pain as well. Intervertebral disc disease, Wobbler's disease, meningitis, I guess, too. And then what was the other part of the question? State your leading differential perhaps discospondylitis, given the temperature and the age of the patient. Do you have anything else to add, Julian?
Would anyone like to add any other differentials? They were all great, Georgina.
I would consider steroid responsive meningitis arteriitis and like immune-mediated polyarthritis maybe as well.
Excellent. Would anybody like to expand on the meningitis differential?
As in like a bacterial meningitis versus a, I mean, you're unlikely to have a viral meningitis or a parasitic. Is that what you mean?
Yeah. So just give some further differentials. Yeah. So bacterial could be one. Viral, like you said, we're lucky because you don't get a lot of like distemper and rabies, but sure. Anything else?
Protozoal meningitis.
Like,
Toxoneospora.
excellent. Yep.
I'm wondering also about rat lungworm, whether that might be possible.
Yeah, absolutely. I think we should have that on the what causes rat lungworm?
Rat lungworms. Now, migrating larvae, if the dog has eaten slugs or snails or some countries crustacea.
The Angiostrongylus.
Yeah.
Important thing to remember about treatment with that is not to use a parasiticide,
Mm.
to use an anti-inflammatory.
They've changed their minds, Jeff.
Sorry?
They've
Anna?
changed their minds.
Oh, have they?
Yeah. Sorry. I think we're hijacking. Jumping ahead.
Yeah, so I think all of those differentials were great. And Georgina, I really liked how you gave your rationale for why you put disco at the top. And the other things, just to recap, that we just added on were infectious, so like protozoal, viral, bacterial. You could also have fungal in there if you so wish, and canine, neuronal, angiostrongylus, so angiostrongylus cantonese. What is it? Cantonesis? Yeah.
Cantonensis, yeah.
We should add in as well. In my exam, they asked me for the names of the types of feline lungworm. If anyone had that, and I hadn't learned the names of any parasites, so let's learn that one together.
Is there another one called Irugo?
Irostrongylus abstrusus.
Yeah, that one.
That's cat lungworm.
Yeah, the cat one.
Yeah.
That's
the one
a
Helen got quizzed on. There's also one called capillaria or something as well, I think.
Yeah.
As
we now know, because that's what they asked me about in my exam. I don't really know the names, but
the cat lungworm, isn't that a UK thing, not here much?
Yeah. We don't see it often in Aussie.
Rat lungworm, did you say?
No,
cat lungworm.
Cat.
Compared to in England. Yeah.
Yeah, no.
The other thing might be interesting is the geographic history of where this dog's been. Might be helpful.
Yeah, that's really true, actually. And could ask about we could throw tick-borne diseases on there for that reason. That's a great point. Yeah, we've got infectious, and we also added on the immune-mediated conditions. So like SRMA, steroid responsive meningitis arteritis, and IMPA, immune-mediated polyarthritis. I think are great differentials. Cool. Oopsie. Okay, outline an initial stabilization and thorough diagnostic plan for your patient and assume no financial limitations.
Okay, so initial stabilization and thorough diagnostic plan. So stabilization, fluid therapy, supportive care, crate confinement.
That's a nice one, yeah.
Patient, ensuring that the patient is eating, drinking, urinating normally. I guess consider feeding tube placement if the patient has had prolonged periods of anorexia. Thorough diagnostic plan would involve initial minimum database, including CBC, to check for systemic infection inflammation, and also would be useful in having more confidence that there's not something tick-borne going on. Usually if there's tick-borne disease, there'll be thrombocytopenia, neutropenia. Assessing the biochemistry for normal organ function, electrolytes, protein levels, and urine analysis to confirm normal kidney function prior to a general anesthetic. And also, again, useful for tick-borne disease, as you may also see proteinuria in the urine sample. So the more specific diagnostic testing would include a CT MRI to assess for things like meningeal enhancement, rule out any sort of masses within the spinal column, and also within the forebrain. I know it doesn't have any forebrain signs, but good to scan that area too. It would also be useful for ruling out intervertebral disc disease, Wobbler's disease, and then performing a cerebrospinal fluid tap after you're confident that there's no contraindications of doing so, such as a mass effect.
Excellent.
And the cerebrospinal fluid assessment would include a total nucleated cell count assessment. So typically the total nucleated cell count is really low. I've forgotten the exact number.
It's okay.
Really low. And similar to the protein. So there should not be much protein in this tap. And this would also allow a collection of samples for PCR testing. So for toxo, neospora, and Bartonella, I guess, and also fungal culture and bacterial culture to help rule out things like a bacterial meningitis and fungal culture as well. Certain things on the CSF tap that may suggest parasitic disease would be an elevated eosinophil cell count. So similar to a viral infection, or yes, a parasitic or fungal infection. Suggestions that there may be something like meningitis would be a elevated non-degenerate neutrophil cell count with the absence of intracellular bacteria, and negative PCR and culture testing. Did you want me to continue alluding, or is that enough?
Are you happy?
I think that's most of it.
I think that was a really good answer.
Okay.
Yeah. I'm sorry, it's so awkward when we're just standing here, I know. No, I think that was really good. For bonus points, what else might you want to do to the urine in the context that disco was one of your leading differentials?
Oh, culture for sure, like bacterial and fungal culture.
Amazing. Yeah. Perfect.
And you could do like a L-galactoman fungal if you're concerned about disseminated fungal disease as well.
Yeah. I think great shout. No, I think that's a really good. And I know it sounds really obvious because you did say CSF get like the total nucleated cell count, but I'd just say cytology as well. I know that sounds obvious.
Cytology, yeah.
Which you alluded to, and the CSF cytology fluid assessment. So like you said, the cell count, the protein, perfect, the PCR. I think it would also not be wrong to say you want to do joint taps in this patient.
Yes.
I don't think you'd have to pass this question, but if you said that, I think that would also be really reasonable. That's pretty. I'm happy. Everyone happy with that? Yeah, I think that was really thorough.
Could you also
Okay.
sorry.
No, go for it.
Could you also do serology on toxo and neospora as well as the PCR?
Yes, actually, yeah, that's so true. I didn't say that. Yes, for sure. You definitely, you could definitely do serology too.
Cool. Thank you.
Okay. Diagnostic results. So the patient has a full body advanced imaging, which is unremarkable. CBC in biochemistry is normal. The CRP is markedly elevated at 99 on a reference range of 0 to 10. Urinalysis is unremarkable with a negative culture. You perform a CSF tap and submit the CSF fluid for PCR, which is negative, and that's including distemper, crypto, toxo, neospora, and angiostrongylis. You perform CSF cytology, and there is a picture there. Interpret the diagnostic results and states whether this supports your leading differential. Can I just make a quick thing? If, for example, you list tests, because this happened to me in my exam, and I didn't list something, and then on the next page, it was like, you think it's this. And I was like, oh, I didn't even talk about that. Don't worry, it really doesn't matter. So, for example, like the lepto case, in the first bit, if you haven't said anything about lepto, and they're like, okay, now it's got lepto, it's really easy to then think, oh, wait, no, sorry, and just move on. It doesn't matter. It definitely does not mean that you haven't got a great question or won't pass it. So even if here you now change your mind about your leading differential, that's completely fine. You can say, my initial leading differential is this would lean more this way. Okay, would anyone like to have a go at this question? Interpret the diagnostic results and state whether this supports your leading differential.
So there's a marked pleocytosis, which is predominantly neutrophilic, which would support my leading diagnosis of steroid-responsive meningitis arteritis.
Perfect. Do they look degenerate or non-degenerate?
Non-degenerative.
Yeah.
No.
Yeah, I agree. So we've got a non-degenerative neutrophilic pleocytosis. Yeah, beautiful. I think that's all you need to say for that question. And I guess I've asked the diagnostic results. You could also just comment that it supports it as well because of the CRP. Oopsie, and the negative. Okay, if this was the cytology instead of the previous slide, but exactly the same case, but this is your cytology, interpret this cytology, and if this was the cytology that you obtained from the patient, how would this alter your assessment of this case?
There's like a mixed, it's like still a marked pleocytosis, but it's mixed with monocytes and lymphophilic as well, and neutrophilic and eosinophilic. Like I would consider more with the eosinophils, you could consider the parasites, but then also just like MUO, meningitis of unknown origin as well, would go further up my list because it's not neutrophilic. Yeah.
Yeah, beautiful. Yeah, and great assessment. You don't have to go into loads of detail. If you just can try, I know looking at cytology is overwhelming. I hate it, but that's perfect. Just trying to pick one cell at a time, think what's that most likely to be, try and comment on the cell types that are there. If you have no idea, you can also try and describe the cells, just so you show that you've got a logical approach to cytology. Yeah, great. So mixed. And everyone happy with all these little eosinophils? Can you see my mouse when I'm screen sharing?
Yeah.
Okay, great. Everyone happy with these little
Is there
nice, beautiful pink?
Yeah. Is there some degenerate cells there too? Like top right corner, top.
Oh, like this guy?
Yeah. And then the one next to him and the
potentially, I wouldn't even worry about that too much actually in this question. I try and exactly like Ingrid said, the cell types and focusing on the fact that there's eosinophils in a mixed population, so it might alter your differentials. Yeah.
It's not septic.
Okay, great.
It might be worth stating that it's non-septic.
Yeah, that's a really good point, Jeff. Yeah, you could definitely state that it looks non-septic. So it still leans exactly like Ingrid said, parasitic or potentially like an MUO or other disease process. Beautiful. Everyone happy with that case? We might try and speed through. I might just do another prognosis one in the last time, just because prognosis does often come up in the orals. Would anybody like to have a quick go and we can have a quick discussion around this. An 8-year-old greyhound has been diagnosed with a left forelimb osteosarcoma by a colleague. Discuss the treatment options available and prognosis for each option offered.
Prognosis for doing nothing is usually weeks to perhaps 3 or 4 months, best case scenario. With surgery alone, prognosis is around 6 months. With surgery and chemotherapy, specifically perhaps Doxo, you're looking at more around 12 to 14 months, roughly.
And in your treatment options of doing nothing, would you do nothing, or would you offer anything else? Is it?
Yeah, of course. So non-steroidal anti-inflammatories, gabapentin. You could also add on IV biphosphates to help palliate the pain and for potentially ionized calcium levels if they're elevated.
Yeah.
And stronger opioids as the pain progresses and the patient, is approaching the end of its sort of life. So fentanyl patches, codeine tablets, things like that.
Perfect. Does anyone want to add anything else? They're really good answers.
Do they use bone sparing? It was experimented with when I was in America, but that's a long time ago. Is that an option these days?
The limb sparing procedures? Yeah, for sure. Yeah, for sure they are. That's a question for a surgeon, but they're definitely options. They do limb sparing. They do, and have you ever seen those like intraosseous transcutaneous implants that they have? So you can like basically chop the neoplastic bone out and then put an implant in. I don't think you need to go into much detail in that in a medicine exam, but exactly like you said, surgery, you could say amputation or other procedure of the surgeon's choice. They're quite cool procedures. And like Georgina, like you touched on, we're going to potentially have better analgesia with amputation, even if we've got metastatic disease. So the patient's life expectancy is probably going to be longer because they've got improved comfort and less risk of pathological fracture. Does anyone know about the metastatic rates of an osteosarcoma on average when at time of diagnosis?
Well, they usually have metastasized by the time you find it in the bone.
Yeah, so potentially even up to 90% in some studies. So if they ask you that in an exam, like, would that change your treatment? It's very safe to assume microscopic mets at the time of diagnosis. So we kind of mentioned doing nothing. I love that you gave timeframes. I know it's really hard to commit to, but they can be quite broad, but you committed really well. So multimodal analgesia, IV bisphosphonates infusions, amputation plus chemo. Does anyone know a weird quirk of osteosarcoma why if you're going to do an amputation, oncologists really strongly recommend following up with chemo? I mean, obviously because they want to treat the cancer, but
because of the micromets that are already present at diagnosis typically. Yeah.
So there's some evidence that they can have really rapid proliferation of those micromets post-operatively. So they say if you're going to start chemo, don't delay for too long. So basically, as soon as stitches are out, when you're safe, 10 to 14 days, start chemo for that risk. You could also chuck radiation in there, which may be palliative from an analgesic point of view. There's some studies that show there's an analgesic benefit, but I think that would be just a bonus rather than necessary.
Yeah.
Does anyone have anything that they want to chat about with that case? with osteocytes in general.
Is the limb sparing only for like more distally affected bone tumors, like in the radius?
That's a good question.
It wouldn't be indicated for like a proximal,
for an upper.
yeah, humerus. Maybe more surgical.
I'm actually not sure. We often see them distal. I'm not sure is the honest answer for that, if it has to be distal or not. That would be a surgeon question. I'm so sorry. Yeah, I'm actually not sure. Do you know, Anna, if it has to be distal limb
For
for a limb sparing procedure?
depends what type they're doing. I think there's a few different types. I think, yeah, I don't know. Surgeon question. I'm gonna have to run, guys.
Yeah, good.
I will see you one more time before the oral exam. So good luck with all your study.
Thank you.
Thanks, Anna. Does anyone have any burning questions before their oral? Thanks, Anna. Or anything that they really wanted to ask or cover today? Everyone doing well? Everyone staying sane? Good, awesome.
Anna, could I have a word after everyone goes?
I've got to run, Jeff. Sorry, I've got a urgent one this morning that I've got to get to. Can we chat maybe later on today?
Just
I'll give you a buzz.
Yeah, that's a good idea. Phone me
Oh,
when it's
okay.
convenient.
All right.
Thanks,
so-
everyone.
Okay.
Thanks so much for joining in, guys.
Thanks, Helen. Hey,
Speak soon.
Helen, are you doing another one?
2 weeks' time.
Oh,
Anna
2
and I will
weeks?
be here. Yeah.
Oh, okay, great. Thank you.
See you soon, guys. Have a
See
good
ya.
day.
Bye.